little, actually, I should say I had a little technological problem. Thank you. I want to begin this morning talking, as we always do, about where we are. And obviously, we use numbers to measure where we are, knowing that even one loss of life is much too many. But I am so incredibly grateful, as I always am, but particularly today, to everybody who's been doing this work with us. Because, as you know, since the beginning of the year, we've been seeing a steady, pretty dramatic decline of over 30% reduction in our numbers every month. And I'm happy to report today that in this past month, we've seen a 41% decline. That's an incredible number. It is certainly not a number that, for those of you who remember, when we first started this, and I'd be coming on every month saying we increased by 15%, we increased by 18%, to say that we have declined at that number over a 30-day period is really amazing. And it is a testament to all of you because you are the ones out in the street doing that. And I am incredibly grateful. And on behalf of the people of the county who don't necessarily know to be grateful to you, I express that thanks. I mean, that is, when you think about it, as I always say, even using the very conservative number of a death of one person affects 10 people. If you use that number and multiply it by the change here, it is absolutely amazing. What is I'm also particularly amazed about is we have seen a decrease, although we have seen continued to see an uptick in those who have lost their life by suicide. With respect to people using opioids to do it, this month we have seen almost a 70% decline in that. So what's happening is working. And, I think sometimes the work is always before us. But this really is time to kind of take a moment and just think about, you know, 8 or 9 years ago when no matter what we did, we couldn't push that number down. So this is a remarkable day. Um, and that's the same thing. I've been spending a lot of time going to events across the county for overdose awareness. And I was at Newton Wellesley yesterday where we planted again the flags out on Washington Street in Newton. So if you drive by there, you'll see that display. But it really has made me reflect on the things that have happened. I actually have had a couple of opportunities in the last few months to go to other places and talk about, we think that we are doing a lot and we're seeing these declines. It is shocking to me that there are still so many communities that are so far behind us in what they're doing. So it's really been my privilege to be able to share what's been happening here and also to talk about what I think is the most important lesson. And it is really what all of you have done is keeping in mind that there was a good 4 years of runway when nothing we did was changing the picture. And I think people, it would have been very easy for people to lose heart during that moment. But you didn't, and people stayed with us, and it has really made an incredible difference. So, I also, in the second piece of what I was talking about is, as you may know, September is National Suicide Prevention Month. And while we have seen a significant decline in those deaths by suicide that involve opioids, we have seen a very concerning uptick in other deaths by suicide. And it is literally across the spectrum in terms of gender, age, communities, all of those situations. And it's just a reminder about how important access to behavioral health care is and how much that continues to be an issue. Last week, and some of you may have been with us, I had the privilege of once a year, we bring together the police chiefs, the fire chiefs, and the school superintendents. And we were at Minuteman High School in Lexington. And there's a lot of reasons for doing that. The primary one has become, unfortunately, actual physical safety. And especially after what's happened at the beginning of school in so many other places, it was really important for us to talk to people about that. And we also, what we've seen in those terrible tragedies in the perpetrators of those events is obviously a missed opportunity, maybe, or certainly a need for youth mental health. And talking to, we had the opportunity to talk to that group about really sharing information, being attentive to kids, figuring out when kids, when it's more than just normal stress that's happening with kids and they need some extra help. And that has often seen itself, and not unfortunately just with kids, but it has seen itself manifested in hate speech and threats. I would say probably half of our communities, and it's only September 18th, probably half of our communities have already had a concerning threat issue in their schools. Threats being called in, threats online, that sort of thing. So that's an important piece. I want to also talk about what we know to be a continuing issue, and it was highlighted by a study published by the University of Michigan that said that of the 19 million kids living in the United States, 25%, or 1 in 4 of them, are living with a primary caregiver who has a substance use disorder. So, if you have kids, you love a kid, you know a kid who goes to school, think about their classroom, and a quarter of those kids, statistically, are living in a household where the primary caretaker is struggling. And it really emphasizes the need for stigma-free resources and a support system. It's hard enough raising kids when you're not also struggling with the addiction issue. And can't, I give enormous credit to people who are trying to do both, but we have to help them out. And we have to be thinking about early intervention. It shouldn't be when the kid comes to school at 5 or 6, um, because they're not likely getting some of the messages at home that we need them to do that. So today we have fortunate to have 3 speakers with us. We'll talk about the landscape of youth substance abuse, resources that are available in our communities for young people, and offer ideas about what else we can be doing to ensure their health and safety. So first, we're going to hear from Connor Buchholz. Connor's a PhD student at BU's School of Public Health. He's in the Department of Health, Law, Policy, and Management. And he's going to talk to us about his recently published study on polysubstance involved opioid overdose youth in young people. And that is, we've talked about this before, that's been an incredible problem. And when we have those deaths and we see the tox reports come back, that is very frequently the case. So Connor, thank you for being with us.
Yeah, thank you all for having me, and it's nice to meet you as well. Just share. I think that worked. I can get rid of the subtitles, then we're definitely. Nope. Okay. All right. Well, today I'll be talking about a project called Trends in Polysubstance Involved Opioid Overdose Deaths Among U.S. Youth from the years 2020 to 2023. I am a PhD student at the Boston University School of Public Health, and this work was done alongside these great researchers here, in addition to Massachusetts General Hospital. These are some of our funding sources. Okay, so I'll first kind of start with a little background. Drug overdoses and poisonings are the 3rd leading cause of death in US children under 19 and are the leading cause of death in young adults aged 19 to 24. Now, most unintentional overdoses in adolescents and young adults or youth involve opioids, with illicitly manufactured fentanyl involved in at least 75% of all of these overdoses. While in 2022 alone, overdoses claimed the lives of more than 1,100 adolescents aged 14 to 18. So what this means is, in every week in 2022, the equivalent of a high school classroom's worth of students, or an average of 22 adolescents, passed away due to drug overdoses in the United States. And this is according to data from the CDC, which we will also be discussing today. However, this increase in mortality has occurred despite drug use becoming less common over the years among adolescents. Excuse me. So the nation's focus on the overdose crisis has long centered on adults, but increasingly, overdoses involve younger ages. So a little bit more of the introduction in regards to this project. Among adults 25 and older, nearly half of all overdose deaths involve other substances, mostly due to stimulants such as methamphetamine or cocaine. However, among adolescent opioid overdose deaths, polysubstance use is less common. And really little is known about the age at which youth overdoses transition from involving only opioids to also involving other substances as well, in addition to the opioids. And understanding the timing of this age related shift is, of course, critical to prevent overdoses. So, the method in which we analyzed this research question is we extracted drug overdose fatalities of youth among the ages 15 to 24 from this database called the Center for Disease Control Prevention, wide ranging online data for epidemiologic research, or CDC Wonder database for short. And data collection consisted of the aggregated or total years of 2020 to 2023. Within this database or application, we identified overdoses involving opioids with and also without other substances, uh, identifying them with these ICD-10 codes. And a little bit more on the reporting of CDC Wonder. So, external cause injury deaths like drug poisonings in this project, they undergo additional review by coroners and medical examiners to basically ensure their accuracy. And this review may include information from postmortem toxicology screens and descendants' health records. Okay, so back to the project. We extracted death counts and rates stratified or kind of categorized by age, sex, race and ethnicity, and census region. And we utilized these underlying cause of death ICD-10 codes, which included accidental poisonings by drugs, intentional self-poisonings by drugs, and a few more kind of labeled assault by drug poisoning and drug poisoning of undetermined intent. So those are kind of the underlying cause. And we calculated overdose deaths involving opioids alone, and these included fentanyl and other synthetic opioids, heroin, methadone, prescription opioids, and this other category, other opioids, which included opium and other unspecified opioids. Next, we calculated opioid overdose deaths involving other substances, including psychostimulants other than cocaine. The literature denotes that this is basically methamphetamine, cocaine, benzodiazepines, alcohol, and other substances, which included cannabis and barbiturates aggregated together in that category. And what we found, unfortunately, is from the years 2020 to 2023, there were almost 23,000 opioid overdose deaths among youth in these age groups. Fentanyl was involved in more than 90% of these opioid overdose deaths, while approximately half of these deaths involved polysubstance use. And we'll see in the next slide that at age 21 and older, opioid overdoses most commonly involved other substances rather than opioids alone. And now we can see here in figure 1A on the x-axis, we have our single year ages from 15 to 24. And on the y-axis, we have our number of overdose deaths. This first black line representing all overdoses from any substance, followed by this blue line, which represents opioids alone. Underneath that is opioids with other substances or polysubstance use, represented by this red line, followed by this orange line that represent opioids with stimulants. So as you can see here, as age youth into adolescents and young adults, we're seeing general increases in overdose deaths, which are due to opioids alone and due to polysubstance use. And I'd like to kind of bring your attention to the ages 20 to 21. This red line representing polysubstance use actually surpasses the opioids alone line, meaning polysubstance involved overdose deaths became more prominent than death due to opioids alone. And a little bit more granular results here, which we'll see in the next figure. Polysubstance involved overdoses comprised of nearly a quarter of opioid overdoses among 15-year-olds, and that more than doubled among 24-year-olds at 58%. And collectively, stimulants were the most commonly involved substance other than opioids alone and were present in 12% of overdose deaths among 15-year-olds, and that nearly quadrupled among 24-year-olds at nearly 41%. And we can see that here in our figure 1b. Again, on the x-axis, we have our single year ages, and on the y-axis, we now have our prevalence, or excuse me, percentage of opioid overdose deaths involving other substances. As you can see here, this first red line represents opioids in combination with at least one other substance or polysubstance use, followed by the next most prevalent substance, which was opioids with stimulants. Just underneath that was opioids with benzodiazepines and opioids with alcohol. So I think the general takeaway is we're seeing increases as youth age from 15 up to 24 and beyond, and polysubstance use involved opioid overdose deaths. We could see a little bit of a plateau maybe around year 2021, but we're seeing general increases among a variety of substances. So what this means is, as we saw in figure 1a, at age 21 and older, opioid overdoses more commonly involved other substances rather than opioids alone. As national data show that the overdose crisis has entered a fourth wave in which overdose deaths increasingly involve stimulants in addition to opioids. And our results highlight these age-specific transitions from deaths involving only opioids to those involving methamphetamine, prescription stimulants, cocaine, and other substances. However, like all research, there are limitations to this project. There was potential for misclassification involved in deaths in CDC Wonder data. If full toxicology testing or reporting may not have been performed at the time the death was documented. And in one of our tables, deaths involving greater than one substance could be counted more than once. Just due to human error, thus percentages add to greater than 100%. And of course, these represent just mere snapshots of shifting dynamics which may soon change. Deaths involving newer drugs like xylazine, fluaz, prazolam are not routinely captured in CDC data. And this analysis did not examine specific differences in opioid overdoses among individuals with different mental health conditions such as anxiety and depression, which I think would be a critical future study to undertake. And I think overall, amid high mortality from overdoses involving illicitly manufactured fentanyl stimulants, these findings suggest that interventions to address overdoses among youth should not have a singular focus on opioids. Of course, there are new guidelines from medical societies that include clinical practice guidelines on the treatment of stimulant use disorder, and they're now available, including recommendations for adolescents. Overall, drug prevention, harm reduction, and addiction treatment need to more broadly incorporate services to address the rising contribution of stimulants, benzodiazepines, other substances, in addition to opioids. And thanks for listening, and happy to discuss any thoughts that may have come up.
Thank you, Connor. Questions, comments?
I have a question, Connor.
Yeah.
Out of these numbers, do you know how many of these cases are DV victims?
Domestic violence victims.
Yes.
On, I think that would be a really interesting kind of, I'll use the word variable as a researcher or point to bring up. Unfortunately, with this database, that's not like a diagnosis code provided by CDC Wonder. However, I think that would be another kind of group that we should definitely be focusing on and how the opioid crisis is impacting this group. And unfortunately, it wasn't not a part of this analysis, or I think this database to be able to look into that further.
Okay, thank
There
you.
are different ways. Yeah.
I think I have a similar question. Um, Looking at variables, obviously you didn't cross kind of reference these with different variables that could give us some more insight, and hopefully future studies will do that. But in your research, like on any previous studies that had looked into something maybe similar to this, were there any indications around like what we're seeing at that age that might be any indication of kind of what's going on in terms of, I specifically have worked with people that are unhoused, so my brain says, I'm curious about housing insecurity or things like that, but similar with like DV. Any like insights that you maybe have?
Yeah, I think certainly housing instability, different kind of, we'll use the word social determinants of health are crucial to exposure to developing addiction, especially at a young age. Poverty, exposure to violence, all of these things, we know as scientists, public health professionals, parents, everything that they make an impact. Um, I'll kind of take this a little bit in a different direction as I think there are a few main reasons that we're seeing these trends. The first is increased exposure among young people to the illicit drug market, containing counterfeit pills where they may be believing that they're, getting a certain medication if they're not getting it through a mental health service, and it may be contained with a more potent unknowing drug like fentanyl. So I think a lot of young people are coming into contact with fentanyl unknowingly. In addition, I think that during the COVID-19 pandemic. It certainly increased mental health conditions among young people. And I believe we're still seeing, effects of that. So I think, increased exposure, increased potency, and then unfortunately, increased mental health conditions that we don't fully have the system to treat, although, there's efforts certainly. So hopefully that helped.
Great, thank you.
Any other questions, comments? Connor, thank you so much.
Thanks for having me.
Thank you. All right, now we're going to hear from Dr. Randy Schuster. Dr. Schuster is an associate professor at Harvard Medical School and the director of the school-based research and program development at Mass General's Center for Addiction Medicine. She is a licensed clinical psychologist and has published and presented widely on adolescent substance misuse and its comorbidities. And through the program that she runs of state and federally funded school-based prevention research, she's been active in collaborative work to develop and test best school-level early intervention programs to really minimize the impact of substance use on student health and well-being. And the training that she's received in community-based research is reflected across the extensive ties that she has with over 400 middle and high schools across Massachusetts. She annually does a survey of nearly 100,000 students in the Commonwealth regarding mental health, access to mental health services. And that survey was most recently published this year in the Journal of American Pediatric Medicine. I think I got that right. And Dr. Schuster is going to share with us some best practices for for intervention and prevention with young people. So thank you, Doctor.
Hi, everyone. Good morning. I'm so delighted to be in community with everyone here, and thank you so much for the invitation to present. I am going to just focus for a second and pull up my slides. Make sure everyone see that okay? In good shape? All right, cool. Okay. So as mentioned, my name is Randy Schuster. I am a psychologist by training and have been based out of Mass General Hospital and Harvard Medical School for this one going on my 14th year, I believe. And I direct our new Center for School Behavioral Health out of the Department of Psychiatry. And that's really going to be reflected in that vantage point will be reflected in what I present to you here. I'm going to take a slightly different approach, and I'll have a little bit of data smattered throughout, but want to give just a bird's eye overview of some of the work that we're doing in our program and just some of the priorities that we're thinking about in terms of how we advance substance use and other mental health prevention and early intervention. And just two things to, I think, underscore even in that overview is when my bread and butter work is really focused on early intervention. So how can we be identifying kids who are at risk for many of the negative outcomes we've been discussing so far this morning, and intervene more proactively on behalf of those kids to try to turn the spigot off, so to speak. Um, and the primary lens through which I view that work is in the capacity for schools to be advancing that work. So you'll see that reflected here. As mentioned, I support a little over 400 schools right now across the Commonwealth. Those are disproportionately represented in Middlesex County. So lots of many of the schools in the county are schools that we have very, very active partnerships with. So happy to speak specifically about programming there. The other thing I'll mention, which is reflected in my title here, and I think is actually one of the punchlines of what I'm hoping to present, is even thinking about substance use and other mental health concerns. So we often talk about we talk about substance use and mental health concerns, like those are on two separate planets. But the data are really strong to suggest that substance use is, and particularly addiction, is a mental health concern. So really even just thinking about evolving our language and how we're addressing substance use prevention in youth, and making sure that our interventions, our prevention programs, our interventions, and our treatment programs are embracing comorbidity, and really thinking about all of the things that can be happening within the same student rather than having approaches that address one of these things in isolation of the other. Okay, so I have, as if anyone's heard me present before, I always have way more slides than we will ever have time to discuss. So I'm happy for this to be a bit of a choose your own adventure. If folks have questions as we're going, I'm happy to field them. Otherwise, also happy to distribute slides that we don't get to today. But just as a quick foundation level setting, most of my science is going to be just summarized in this one slide here. So just to ensure that we all here are on the same page, punchlines. Most teens do not use substances. I think especially for task forces like this and for the work that I do and for the work that my co-speakers do, it is easy to forget that we are still talking about an unacceptable minority, meaning too large of a percentage. Yet most teens are not using substances and are at relatively low risk for substance use. The other thing that I want to summarize here, and I don't present too much epidemiological data in this slide deck, but if we were to look at prevalence rates of adolescent substance use, and my work tends to focus on alcohol, cannabis, and tobacco use, numbers, with the exception of nicotine vaping, have remained largely stable over time. We don't see this dramatic increase, and one of the fears that with Q2, Q4 with cannabis legalization was whether or not that was going to result in an uptick in adolescent cannabis use. In the last decade, we have not seen dramatic increases in use. However, I think those data are often misleading. What those data don't present is how kids are using and how often kids are using. And if anyone here is doing school-based work, I would venture to guess that the kind of stable trends in use don't reflect your experience boots on the ground in schools. All of the schools that we're working with are saying that despite these epi data showing relatively flat lines, this has become much more of an in-school problem than it has in years past. And I think that there are a number of different reasons why that is likely the case. One of the most obvious reasons are the availability of devices that make it easy for kids to use discreetly in public places, which was not as much of an issue in prior years. There is a lot that we don't understand vis-a-vis the impact of adolescent cannabis use on the developing brain. And that is, an artifact of when I was doing my PhD work, what feels like 100 years ago at this point, NIH was not interested in funding cannabis work, right? It was not a very timely public health concern. And now, fast forward, a decade or two later, public policy has far outpaced the science. We have made decisions around commercialization, legalization, before having definitive clinical trials in hand. So there is still a lot of areas where we as scientists are playing catch up, and I can name some of those spaces as we're going through this work. There are a few things that we know for sure. So first is that we know that adolescents are at heightened risk for negative effects compared to adults. Again, a number of reasons for this, probably the primary of which being patterns of ongoing neurodevelopment during this period of time that renders the adolescent brain more vulnerable to the putative effects of really insert any substance here. We know that adolescents who use any substances are more likely to experience other mental health concerns. And again, notice that this is just my pet peeve. Other mental health concerns. I'm not saying more likely to experience mental health concerns, really needing to make the shift that substance use is a mental health concern. This phrase was very, or this sentence is very purposefully written the way that it is. This is not to suggest that substance use causes symptoms of depression or vice versa. In fact, the science really does speak to bidirectional relationships between substances like cannabis, alcohol, and nicotine, and other mental health symptoms like symptoms of ADHD, anxiety, and depression, which we can speak to more in the coming slides. And this is where I really want to sink in, which is mounting data really suggest or speak to the promise that schools can play in uplifting more equitable prevention of substance use and other mental health concerns. And I'll speak to hopefully convince you why schools are a critical piece of the solution here. So the first is that schools provide a critical access point to improve equity. We know that no-show rates for initial mental health appointments are high, are unacceptably high, range between 48 and 62% at most recent estimates. We know that anywhere from a major minority to a slight majority of children receiving outpatient mental health services attend fewer than recommended sessions, drop out quickly. In contrast, schools, while not perfect for access, provide a much more scalable place to reach a large percentage of kids and particularly reach kids prior to the emergence of need for crisis intervention services. We see that a growing number of kids are more likely to receive mental health services in schools than in any other youth serving setting. We also, another reason why schools is it presents the opportunity to enhance connectedness and reduce stigma. We see that over and over and over again in the literature that access to trusted and caring adults is one of the major protective factors in prevention of progression of symptomatology. So schools really present an opportunity to build capacity in the adults that kids are met with every day. We have the potential to leverage the proclivity for social contagion for good here. There was a really compelling study, I believe in JAMA Psychiatry or JAMA Pediatrics, I apologize, I'm misremembering which one, last year, that showed provided some really compelling evidence for lack of a better word, the transmission of mental health symptoms through peer networks, which is quite concerning. But we've also seen data that speaks to the opposite, that if you intervene on one, that particularly in dense peer networks, you have the opportunity to also intervene, have the transmission of intervention effects in a ripple-like fashion to peer networks. We also see that in schools, there is the opportunity, or there is in an environment, I think, unlike any other, to utilize the dense contact and the historical relationships, allowing for more intensive monitoring. I do a lot of work with NIH doing reviews for NIDCR, National Institute of Dental and Craniofacial Research, which there's a big movement to embed vaping prevention work in pediodontist's office, which is fantastic and really cool. However, we see that progression of symptoms during adolescence happens very quickly. And if we are only relying on primary care settings or routine clinical encounters, we miss the opportunity to intervene with early emergent symptoms. Schools, with the exception of home, schools, I would venture to say, is the only space where we have adults who are able to, with proper training, support, funding, all of these things. I'm not saying this is easy, but if we're able to support schools adequately, they are able to, they're in the best position to be able to detect small changes in behavior or symptomatology that might indicate that some intervention might be appropriate. So these are some data that we published just a few weeks ago, actually in JCAP from our school survey work. These data are Massachusetts students in 2024, in the 2024 school year. Again, really, I show these really just to hopefully for anyone who might be on the fence about the value of schools. Hopefully, this moves you a little bit, further over that fence in favor of uplifting the role of schools. Here, what we're looking at, and again, these are our kids. These are Massachusetts students just last year. We're looking at the relationship between neighborhood deprivation. So how much deprivation kids are exposed to in their home environment, in their community environment, and its relationship to mental health symptoms. And what we show here is what we've known for years, which is that as kids are exposed to more neighborhood deprivation, we see a linear increase with expression of other mental health symptoms. So here we're looking at symptoms of anxiety and depression, self-injurious thoughts and behaviors, so suicidal thoughts, non-suicidal self-injury, as well as substance use frequency. But what's novel here is we went through and we coded each school for the ratio of mental health providers in the school context to students. And what we see is that in schools that have a higher than average ratio of mental health providers to students, so they have more mental health staff able to support student needs, that relationship between neighborhood deprivation and mental health expression goes to zero. There's no additional risk associated with neighborhood deprivation vis-a-vis expression of mental health symptoms in schools that are more than adequately staffed with mental health providers. So what I want to do now is just walk you up very briefly and in bird's eye overview the tiers of support. So this here is a very simplistic representation of the multi-tiered system of support, or the MTSS, which is a common framework used in school-based settings to organize interventions in a graduated approach. And in an ideal world, we have interventions, and you can do this for learning-based interventions. You can also do this for behavioral health interventions. And in an ideal space, sorry, I have things popping up on my screen. Hopefully you guys can't see that, but I'm going to get it out of my space. We have interventions that align along this full continuum of care. So tier 1 should reach about 80% of students. About 80% of students theoretically should be responsive to tier 1 interventions. Think these are interventions that are not deployed on the basis of risk. They go to everybody. Think sex education, health ed classes, universal screening. They go to everyone. Tier 2 should be about around 10% of students should be responsive to this. These are our early interventions. So these are interventions that should be deployed to a smaller number of kids on the basis of some early indicated risk. These are not kids, this is in thinking about how this might apply to substance use. In theory, this should be applied prior to the emergence of addiction or dependence, but it is designed to prevent progression, right? Or intervening early. And then tier three are our intensive and individual interventions. Think treatment, think cessation services, think crisis management services. Now, oops, now I can't advance forward. Sorry. Oh, previewing. Hi. Okay. So where I've really invested my work is in this tier two space. In working with schools, and I would really encourage this group to think about how we can be expanding tier two supports in schools. There is a gaping hole in the middle of this MTSS, and there are a lot of reasons why that might be the case. Tier one interventions, they're hard to develop, but they're easy to know who gets them, right? They go to everybody. And they're typically a part of, there's some level of state mandate or it's written into curriculum. Tier three is difficult to ignore, right? If you have a kid in crisis, we know we need to rally supports around them. How we find those supports and how we navigate wait lists and access to supports is a whole other can of worms. I'm sure Carla's going to be getting into some of that. Here, tier two is really challenging because it requires identifying kids who are at risk early and intervening quickly. So we need mechanisms to identify these kids. We also need the interventions to support them. And as I mentioned earlier, kids progress across, for kids that are at risk of progressing up the this framework, that happens quickly. So this really needs to be built into the fabric of schools. So, my Lord, I cannot figure out which way to advance on this. So I'm just going to walk you very quickly up some of the work that we're doing across these three tiers. And I'll go faster through some of these than others. So the first is what we're doing in this tier one space. We do a lot of work around universal screening. Some of this is our anonymized surveys. So we have something called our SURF survey, which is our substance use and risk factor survey. We survey about 60 middle schools and high schools every year. We survey in over 20 languages. And the primary goal of this effort is to provide schools with with tools for data-driven decision making. We look at the expression of substance use and other mental health concerns. It's a longitudinal survey, so we're able to connect records over time and look at risk factors for progression of symptoms, and use these data to meet with each individual school that we're working with to make some decisions about whether or not programs that are in place adequately address the symptoms as they are expressed in their school community within a given year. These are some data from that SURF survey that was published in JAMA Pediatrics at the beginning of 2024. These are Massachusetts students in fall 2023, high school students, about 16,000 kids reflected in this data set here. And just to make a few very simplistic points that I'm sure is not foreign to this audience here. Here we're looking at the frequency of alcohol, cannabis, and nicotine use, each represented in different dots, and the relationship between past month frequency of use and expression of other mental health concerns. And I'll just highlight big picture what we see. As substance use frequency increases, so too does expression of other mental health concerns in a very predictable and somewhat dose-dependent way. If you look at this top left figure here, we're looking at frequency of substance use and endorsement of suicidal thoughts. And I'll make one point here that it is among kids who report never using any substances, it is only in that group where we see that the base rate of suicidal thoughts is consistent with what you would see in the general population. About 11% of kids who have never used substances report having thought about suicide in the last year. Once we get out to daily or near daily substance use of any substances, we see that between a 5 and a 6-fold increase in endorsement of suicidal thoughts and behaviors. It's about 1 in 2 kids who are using substances daily report having thought about suicide in the last year. We also see that risk for substance use is not shared universally across all kids. So from our SURF survey here, what we're looking at is, and I picked sexual orientation as just one variable to illustrate this point. We could cut this by gender identity or other mental health symptoms. But essentially that the rates of substance use are nearly twofold higher in kids who identify as sexually diverse compared to those who identify as heterosexual. Not to suggest that there is some organic cause here. This is likely driven by traumatic exposures in kids who have various minoritized or marginalized identities. But again, really speaking, especially in the challenging times that we're in right now, really making sure that the interventions that we're deploying in school-based settings are sensitive to the unique needs of kids who identify as sexually diverse. Here I'm showing you those who identify as gender diverse. Here I'm showing you among kids who are at risk for psychotic illness. The pattern is exactly the same. So we really need to make sure these interventions are specific. And I think those early interventions provide us a really great opportunity to tailor. The last thing two quick additional things I'll highlight in this tier one space is around SBIRT. So SBIRT is state law in Massachusetts. It went into effect, I believe, in 2020. SBIRT is screening, brief intervention, and referral for treatment. And our state requires that every middle school and high school screen one grade, one middle school, one high school grade every single year for substance use. Problem is, this has been an unfunded mandate. And schools have had a real challenge getting this off the ground. I'm going to give just high level here. I'm happy to dive into details around SBIRT. Many schools have said this just feels like a box to check. It feels performative and isn't actually working well on behalf of students. So we have some funding through PCORI and the Mass Department of Public Health to try to figure out how we can do SBIRT screening better. The main thing that we are evaluating here is the utility of embedding youth wellness coaches or near peers within school-based settings to help advance universal prevention efforts. So we, through funding through the state, have between 10 and 15 youth wellness coaches who are deployed statewide to help support in 20 high schools the universal screening mandate that is SBIRT. To date, so we are just entered into year 3 of this project. Our youth wellness coaches have screened over 10,000 students. And importantly, we see that rates of substance use disclosure in kids that are screened by a near peer, by somebody that is not school staff, but embedded within the school community, is nearly double as high than when this screening is done by school staff themselves, right? And this is not to celebrate higher rates of disclosure, right? This is to actually acknowledge that we're getting more truthful and more that those conversations are perhaps more representative of the actual student experience and therefore allowing for more opportunity for intervention. I think the other promise with doing universal screening well is it becomes another tool for connection to care. From our school data, we see that unlike what many people might suspect, that a large percentage of students who are using substances report that if they were offered support today, they would be interested in making a change. They would be interested in either reducing or quitting their use, which runs contrary to, I think, the way that we typically think that kids are clinging tightly onto their substance use. When actuality, most kids are fearful of punishment or they don't know where to go to get support. So what we've started to do is at the end of our surveys, give kids the option to break confidentiality and actually allow us to connect them to school-based care. And we see that in our school survey, so last year we surveyed about 30,000 kids, 1 in 5, when they were offered explicit support around their symptomatology, opted for a warm handoff back to school staff. Most of these kids were not already connected to school-based supports. So a lot of what we're thinking about is how can we find moments, right? Not the, the big flashy interventions, but how can we use the things that are already part of the school environment to normalize access of support and to create clear referral pathways? Just for purposes of time, I'm going to move past here. All right, so I'm walking us up now to tier two. And this is where I've spent the majority of my time over the last probably about 5 years, is in thinking about how we can advance school responses to substance use infractions. So dating back to the 90s, schools became a zero tolerance environment, right? And so for kids who are in violation of school substance use policy, meaning that they come to school intoxicated, they are distributing or they are using on school grounds, the most typical response to those violations is a punitive or disciplinary response. From our data, this is a survey of Massachusetts educators a few years ago. We see that out of school suspensions, in school suspensions, detentions, and citations were only next to parent conferences were the most common response that schools deployed relative to addressing a substance use violation. However, by these same educators, these responses were rated as the least effective approach that they have in their arsenal. We also see there's a lot here. I will boil this down. These are, again, our kids. These are Massachusetts students that not only are punitive responses the most common strategy that Massachusetts schools are deploying, the least perceived to be the least effective strategy that schools are deploying, but we also think that they are likely to do harm. So here we are looking at students who have been suspended in the past year for something related to substance use. And what are they more likely to present with? We see that students who are suspended are more likely to be male, more likely to be racially or ethnically minoritized or marginalized. And I will note without any difference in the actual reported rates of substance use. So we see no differences in actual substance use behavior among racial and ethnic minoritized or marginalized students. We see that these kids who have been suspended are more likely to have poor or failing grades, more likely to be on an IEP, more likely to be at risk for psychotic illness, and 5 times more likely to have attempted suicide in the last year, right? And needless to say, the punitive response alone does not address all of these, many of these comorbidities. It is, it's a surface level response. And when we actually follow these students over time, these kids are actually more likely to progress in symptoms.
Oh, yeah. Yeah, thank you.
I will wrap quickly, but I'll share. This is one of my favorite quotes. This was from the APA a few years ago, actually several years ago at this point, but I think still holds very true, which says that there can be no doubt that schools have a duty to use all effective means needed to maintain a safe and disciplined learning environment. Beyond the simple responsibility to keep children safe, teachers cannot teach and students cannot learn in a climate marked by chaos and disruption. About this, there is no controversy. Disagreements have arisen, however, over the methods used to achieve that aim. Although it seems intuitive that removing disruptive students from school will make schools better places for those students who remain, or that severe punishment will improve the behavior of the punished student or those who witness that punishment, the available evidence consistently flies in the face of those beliefs. And in response to this, our team has developed a program called I Decide, which hopefully some folks here have heard about. This is in about 400 schools across the state. This 1,000 facilitators is now very outdated. We've trained nearly 2,000 facilitators across the state. And this is a program that it's funded entirely by the Department of Public Health, by BSAS. And it's a drug agnostic, non-abstinence centered alternative to punishment. We are really encouraging schools to train lay providers, so this can be delivered not just by their clinical team. And it is really intended to provide schools with a reasonable and restorative alternative response rather than just removing kids from the academic space, but instead starting to address those co-occurring other mental health concerns, the reasons for use, and starting to create a safe and trusted environment where kids who we know are at risk for suicide and overdose death to start to talk about what function substances are serving in their life and start to provide tools and strategies to address those functions. All right. Now, I am sure I have gone over time, so I am going to skip my tier 3 work and happy to address any questions. This is my direct contact information if anyone wants to connect offline. I'm also happy to take any questions or comments now.
Thank you. That was great information. Questions, comments? Oh, let me see. I can't see both all our screens, so if people have, feel free to just raise your question. All right. All right. Thank you, doctor. Thank you so much.
My pleasure.
Now we're going to hear from Carla Gonzalez. Carla is a behavioral health leader and a public health strategist. She has over 25 years of experience in advancing really equity-driven innovations across healthcare, education, and community systems. She holds a dual master's degree in clinical mental health counseling and expressive therapy. And her career began in community psychiatric rehabilitation, where she worked directly with individuals and families who were tackling how do you navigate complex behavioral and social health challenges. Carla currently serves as the director of the Massachusetts school-based telebehavioral health program, pilot program, at the Brookline Center, where she oversees the statewide implementation, evaluation partnerships, and workforce development that's focused on equity and sustainability. Her experience spans managed care, integrated care management, clinical quality systems, policy innovation, with a consistent focus on really looking at the social determinants of health and expanding cultural and linguistic responsive services. In addition to her leadership of nonprofits, Carla is a human design career and resource building consultant, business consultant, mediation teacher, and founder of the Resiliency Rise community. So, Carla, thank you so much for being with us.
Thank you so much. And thank you so much for pronouncing my last name correctly.
Hey, how are you?
Many people don't. So that
Hey, how are you?
is great. So good morning. Thank you to the District Attorney's Office and also to you all our partners across education, health, and community. I'm really grateful to be here and for the chance to share how the school-based telebehavioral health pilot is meeting students, families, and caregivers where they already are, which is either at home or already at school. So I do have a slide deck prepared for you all to share information and more as a reference. So I will project that. Just give me one moment while I share. Let me know if you can see it. Okay, great.
We can see it.
Great. So I just wanted to talk about the goal of the presentation. I do have about 20 slides, so not that much, but I won't be reading straight from the slides. I want this to be more of a conversation. And our goal to present this information is really twofold. First is to leverage, to really understand how we're leveraging the technology and the innovative care pathways through the school-based telebehavioral health program. And I'm going to just abbreviate that to SBTBH because it's a mouthful. And really to meet the demand for behavioral health services. And second, the goal is really to address the social determinants of health. That's at the cornerstone of our program, which is an equity-driven program that is fully funded by the Department of Public Health. And the Brookline Center was awarded this grant to serve as the lead implementation partner. So I just wanted to put that framework into place. And I just wanted to familiarize some of you that may not know about the Brookline Center, about our mission and approach. We've been around for a very long time, since 1958, and the center was founded by a visionary community member here in Brookline, Edna Stein. And the center has been a longstanding provider of quality community-based mental health care in diverse catchment areas, and really has expanded some of the programs to a national base across the United States. The center has always remained committed to inclusivity and cultural responsiveness, diversity, and racial justice and equity. And we feel that the school-based telebehavioral health program, or SBTBH, really exemplifies the mission of the center, but also the community-based approach that feels very non-threatening and serving people where they're at. And in this instance, it would be either in their home or in the community, or whatever preferred setting in the school. And we have other programs through our Innovation Institute that provides mediation services. We have a full outpatient program at our headquarters in Brookline. And we also have early psychosis detection and testing program, which is one of the very few in Massachusetts. So we have these wide range of programs that really help to impact the unmet needs and address them of our community members, and also with a compassionate, equity-driven lens, really to help our partners in the community and to develop resilience to be able to manage their concerns. And the pilot has been around since 2021. We won a bid through the Department of Public Health, and we were selected to serve as the lead implementation partner to really expand the equitable access to SBTBH services across the Commonwealth. And we do implement and have a steering committee that we consult closely with, that includes interagency state partners, social care organizations, and other community-based organizations. We work very closely with the Department of Mental Health, the Department of Elementary and Secondary Education, DESE, as well as other research partners. We work with Randy and Math Brigham on certain projects as well. Just to give you a taste of some of the community partners we work with. And this initiative really is aimed at responding to the urgent behavioral health crisis affecting children across the Commonwealth, but really globally and across the nation. We do feel like the program was launched at a time when there was a crisis point where the pandemic hit and the behavioral health issues really came to the forefront. But we do acknowledge, especially me, since being in this field for so long, that these issues have been longstanding and they're just getting worse and worse because of different factors. So we find that this pilot really provides an innovative, equity-driven model of care that I'll get into in a little while. These are our program goals. I won't go through too much into them because I'd like to talk about them throughout, but these are our basic goals, that we are here to reduce barriers to access to care, especially in communities with known health disparities. So we don't really focus in communities that are not demonstrating a high behavioral health need. And we also want to look at different models of care and test them out so that we can extend successful models into under-resourced communities. And like I mentioned before, this is an equity-driven program, so health equity is at the forefront, and we really look to address inequities in behavioral health integration among high priority populations, which Randy spoke a little bit about through her programs as well. And our goal as the lead implementation partner, we have different responsibilities. We are not the direct service provider, although the Brookline Center does have direct service providers in the tier 1, 2, and 3 MTSS framework that Randy talked about. But for this program, we are not a direct service provider. We are sort of the shepherds and facilitators that gather community collaborators together and demonstrate the feasibility, scalability, sustainability, and elements necessary for successful replication across the state. If you have any questions or insight, feel free to shout them out. Hopefully, I want to make this interactive as possible in the little time that we have. I do find that it's important to talk about our alignment with the task force goals. And again, we're really grateful to be able to share this time with you all and be part of the task force. But we really feel that our program strengthens prevention infrastructure by embedding care directly in schools through community and caregiver engagement as well. Someone said yesterday, not yesterday, but last week, where I met with the Salem Public School parent and their daughter, and they said to me, you know, that saying, it takes a village. And she said, well, there is no village anymore. And a lot of people are feeling that stress of being alone in this. And so we hope to bring community back into the framework and to really look at how to enable caregivers to really be heard and be present in their students' journey through the concerns that they're experiencing. And we also support the focus on recovery instead of punitive interventions. We do use a data-driven model to make real-time actionable decisions and inform policy and resource allocation. I do sit on the Health Commission, the Massachusetts Health Policy Commission, working on behavioral health, workforce development, and other projects to make sure we're really tackling all the factors that are impacting our families and students. And then we also contribute to the Commonwealth's dedication and commitment to better address access to cost-effective, quality, and timely youth behavioral health services. And one of the things, I've been with the Brookline Center for about 2 years, and one of the things that I've always noticed, no matter where I go and what capacity I'm working in, there's a lot of resources in Massachusetts, but there's also a lot of system silos that prevent access to care. And I hear this a lot through surveys that we administer to our families, caregivers, and students, as well as the feedback that I get or I've observed through our district partners and clinical providers. So it's kind of like, oh, we have silos, but I think that there's more conversation that needs to be had, especially in community, to try to really break down those competitive silos because we're all in this together. And so we do have a multi-agency partnership, like I mentioned. These are the most stark ones, but the Department of Public Health, our funder, Department of Mental Health, and DESE as well. And we do consider our school districts our ultimate partner. They're the ones who choose the clinical provider that they would like to work with. We don't work with any private schools, as you can imagine why. And then also we work with regional vocational technical schools, charter schools, and public schools. We do vet clinical behavioral health organizations. We only work with licensed clinical behavioral health organizations and really try to match up the school district with the best clinical provider that can serve their needs and the needs of their unique community. And then we also aim to bridge systems, so education, training, health, and social systems, as well as research. Our approach is an integrated care approach where the clinical coordination is something the school does not need to worry about. We do all that through the clinical provider and also healthcare system navigation and social care management through our community health worker framework. So our role, now we're in the 5th year, right? The initiative really emphasizes early intervention, behavioral health integration. For the past 4 years, the focus has been more on mental health, but we are developing SUD or substance use disorder referral pathways in collaboration with community hospitals and partners. But we also offer completely free professional learning opportunities to all our partners in the districts, our clinical partners, social care organizations, anyone in Massachusetts that works with youth or wants to work with youth and also caregivers. We last year, for example, we conducted about 43 professional learning opportunities to the community statewide. And also we do offer CEs, which is very attractive to our audience. And we also provide technical assistance and continued service delivery to the K through 12 students, caregivers in primarily underserved, urban, sub-rural, and rural communities. We do work with an independent evaluation, which we consider our team members through JSI. We previously worked with Brandeis University. They're really tasked with tracking outcomes and ensuring accountability, highlighting fidelity to the model, and also making sure that we're capturing the student and caregiver experience and satisfaction, but also looking at system level impact. Is this model feasible? Is it adoptable? Is it adaptable? And is it sustainable? And of course, I won't get into too much about equity because we've been talking about it, but this pilot directly addresses social determinants of health by ensuring specific, relevant, and culturally responsive, linguistically accessible care and connecting families to housing, food, and stability supports that drive behavioral health outcomes. We have an equitable care fund that we are very, very happy that we're able to disperse funds so students and families that don't have insurance coverage or are underinsured can still participate in the program. Okay, so how do we prioritize which school districts we work with? We conducted a community needs assessment, which is being revised in 2026. The last community needs assessment was conducted in 2022 in collaboration with Brandeis, our previous evaluation team members. And the findings from that community needs assessment let us know that about 43 school districts across the Commonwealth were identified as having demonstrated high needs in terms of behavioral health service demand and not enough supply. And the districts are prioritized and stratified based on a tiered system ranging from from 1 to 5, so low, moderate to high needs. And so these are the 43 that you see on the map, the heat map, that were identified. And so we really prioritize reaching high need communities, as I mentioned before. So out of those 43, we're currently contracted with about 44% of the identified mass school districts. And there are about 4 that are not prioritized in the needs assessment on paper, but we do find that they had a high need in terms of factors such as demographic or geographic location. And we, just this year, we implemented about 4, and we have 2 other school districts that are pending implementation. So the program is fast growing and expanding as we would like that to happen. And I do want to talk about when is SBTVH appropriate. We do get a lot of comments about, hey, is this replacing in-person services? And we really want to make sure that it's clear that nothing would ever replace in-person services. That will always be around, but the demand for services and the impact that it's having on our communities and schools and caregivers to get in-person services, there are a lot of long wait lists, as you already know. So we think of this approach as supplemental. And then we've also surveyed our families and students, and some of them do prefer TBH for different reasons. And those reasons are usually that they eliminate barriers to timely care, so no wait lists, and also the transportation barrier, especially in rural communities. A parent could be schlepping their kids to an appointment and they live across town. It could take 2 hours of their time and they're working, and then they see that they're not able to commit to that. And then also the stigma of, meeting with a counselor, going to a clinic. And then we also do think that it impacts the SDOH of language access, because we are able to quickly connect someone to an interpreter or be able to have multilingual clinicians that we can match up with the student. And then, of course, the caregiver work constraints. I was a teen parent and I was a very good parent, but I couldn't always take my kids to their appointments because I either didn't have a car or I had to be at work. And it wasn't like, not everyone works remotely with that flexibility. So people physically need to be on site and don't have the flexibility of leaving work, bring their students to an appointment. So we feel this model actually does impact the no-show rate. We've seen that through the data collected. And about 82% of caregivers were satisfied with the services their child received. 80% of youth reported being satisfied with the online sessions and leveraging the technology of virtual care that they had with their counselor or clinician. I am not able to see the chat, so if there is anything in the chat, please let me know. How does it work in the field? How does this model actually work? It might sound good, but how does this actually work? So as the lead implementation vendor, we are financed by the Department of Public Health, and we make sure that the program is successful and address any barriers to it being successful. We're the stewards of public dollars, and we monitor all the contracts. We are currently contracted with about 24 schools, and at the end of the year, it will be 26 school districts, and about, by the end of the year, 4 clinical providers. And our goal is to also drive continuous improvement and be in the field and listen to what the barriers are, what the constraints are, and continuously improve our approach. And we help the schools build capacity, coordinate services, and track success metrics. Randy talked a lot about academic success metrics, disciplinary action metrics, the school level data. We collect that as well. And then we also collect student level data, the clinical data in terms of the clinical one-on-one sessions. And then we do have care coordinators and community health workers that are there to assist with community resource planning and make referrals to support students beyond the clinical session, which we see a lot of that. And the students and caregivers, they have access to telebehavioral health services where the student is studying in the school or in home. And we ask them to share feedback to improve the program. And then we do work with the clinical providers on process improvement, building infrastructure to make sure that the services that they're delivering are quality and timely. And we do share with them our clinical outcomes and implementation data to also refine their business processes. These are the active school districts that we're currently in, the ones that I mentioned being implemented by the end of the year are not here, but those are Springfield and Franklin County Vocational Technical School. These are different models that we're testing out, and we have dedicated elements across providers. So no matter which school district, the provider has to be licensed, and we have embedded into the framework care coordination, so the school doesn't have to worry about that, the scheduling, the resource planning, and things like that. And we're currently working with Codman Square Health Center. They serve Randolph Public Schools. We work with Haywood Hospital. They serve 4 school districts in the central and western part of the state, and also Cartwheel Care. They serve currently about 18 different districts and in different geographical locations because of their ability and infrastructure to deliver multilingual on-demand services that those schools are choosing to make sure Cartwheel can provide. Model 1, the services are delivered in the school, so the TBH sessions occur at the school with an on-site community health worker support. So the community health worker is the one that really spearheads the referral process and works with the clinical staff at the school and brings the student to the confidential room, sets up their tech, makes sure everything's working, and then also after the session helps the student decompress, address any issues. We never want a student to go back straight to class if they have any concerns after the session. And then the community health worker speaks to the family and is in charge of family engagement and addressing any needs beyond the clinical session. Model 2, the services are delivered at home. The TBH sessions can occur outside of school or at home or in school during the school day, but we see more of it at home because that's what the caregiver or the student chooses, with the support of a CHW or a virtual care coordinator. And then this is our statewide pilot reach. In total, there have been 34,000 TBH sessions completed, about 18,000, a little over 18,000 intakes. And yeah, so this is our reach currently. The common diagnosis that we see, I don't think it's any surprise, at the top of the list is stress and anxiety. I think our whole society and a lot of us on the call are stressed and anxious for different reasons. And then attention and conduct disorders and mood disorders and other. Addressing the youth substance use. We have a small pilot with Haywood Health, who serves the 4 districts in the western central part of the state. They've been community partners for a long time, and they've actually have been implementing SBTBH since 2017. And they're the ones who spearhead the community health worker model that I've been talking about as well. In the survey administered to youth, about 80 youth involved in the program, about 85% of youth reported no substance abuse. So we know that not all youth use substances. That's great. However, there is, among the reporting cohort, about 15% do report use, and we want to know what their substance use is, and so that we can see which intervention suits them based on what their needs are. So 81%, about 12% overall report using cannabis, and 40%, 6% overall nicotine, 3% or 17 reporting using alcohol, and 20%, which is 3% overall, report vaping. 9% report using other substance, which is about 1% overall. And we're really curious to understand who are these students and which substances and which interventions would help impact on them and their needs. Randy talked a little bit about iDecide, but we also see students participating and refer to ACRA and Project AMP. And these are some statistics in terms of their participation. I know I don't have a lot of time, but the future direction is we have a partnership with Boston Children's Hospital to shape a SUD referral pathway that leverages community health workers and brief universal assessment tools, and really prioritizes contingency planning strategies, incentivizing participation in the program, and integrates behavioral health and primary care. The focus is really based on what is the actual root cause that is making the substance use a concern. So maybe not addressing the substance abuse head on, because these are youth and they don't want to talk about that because of the stigma or whatever reason. But if they come in and there's an indication of substance use, we look at other factors that could be exacerbating the substance use. And also, if they want to use medication-assisted treatments, they would have the CHW work with a primary care provider to address that. And then we're focusing on the full continuum of care. So really trying to engage the Massachusetts Community Behavioral Health Centers, the CBHCs, and other community partners. We're working on a replication guide for statewide adoption, which is currently under development. And we have a set budget that we apply for every single year that renews. We've been blessed that this budget hasn't been cut. However, it's the same budget year over year. So we're really looking to have more viable, sustainable funding options. So third-party payer maximization. A lot of the support costs, such as the CHW in the schools for telebehavioral health, is completely not covered by insurance. we fully support those roles. We're also looking at private support, private funding support, and working with state policy advocates for coverage of non-reimbursable costs. I think the call to action, and I think we're all committed to this, is really to ensure that every student has access to timely and quality and equitable care. But also looking at sustainability requires policy and funding support to do that. And expanding SBTH really, to me, and I think everyone would agree, is preventing tomorrow's SUD concerns. So we feel that the collaboration with the DA's task force really will strengthen this community impact. These are just some resources that you'll get access to these slides. But you know, if you need to look at more information, we have our annual report. We're finalizing the FY25 annual report. We'll put it up on our website by the end of this month. And then if you're interested in other Innovation Institute programs through the Brookline Center, there's a link for that. And then I know a lot of people might be interested in the community needs assessment. It's a very large volume of documents, but it's very interesting if you have time to read that. And then just our webpage and quick links to that. Any questions or insights?
That was great information, Carla. Thank you. Anybody questions, comments? All right. Thank you so much. Thank you so much. And thank you to all of our providers. Excuse me. Dr. Armstrong has shared a flyer in the chat for an event tonight in Winchester exactly on this topic. So that's available to people. And again, thank you to, excuse me, thank you to our presenters and thank you to everyone for being with us. Take care. Bye-bye.